This week on the Back Table Podcast.
And I think that idea of using some of the technologies that do come from, the same idea of our navigation in our phones and our cars, like using augmented reality or virtual reality, which is part of some of these systems, is just one more element of staying oriented and knowing where you are. So I think being able to use that, and I do make the point that you want to make sure that you're using all of your visualization tools together in an ecosystem to make you as safe and effective as you can be.
Hello, everyone, and welcome to the Back Table ENT podcast, where we discuss all things ENT. We bring you the best and brightest in our field with the hope that you can take something from our show to your practice. Now, a quick word from our sponsor.
Stryker's ENT solutions offer the control you need, the flexibility you want, and enable you to deliver the experience your patients deserve. With Stryker, you gain access to the most complete suite of solutions to help make your vision of patient care a reality. From technology to training, from reimbursement tools to patient education, Stryker is there to help. Together with their customers, they are driven to make healthcare better. Learn more at ent.stryker.com. The opinions shared in this podcast are those of the physicians and not the sponsor. Now, back to the show.
My name is Gopi Shah, and I'm a pediatric ENT, and I have an awesome guest today. I have Dr. Raj Sindwani. He's a professor and vice chairman for the Department of Otolaryngology, Head Neck Surgery, at the Head and Neck Institute at the Cleveland Clinic. He is world-renowned in sinus and skull base, and he is here to talk to us today about navigation and sinus surgery. Welcome to the show, Raj. How are you?
Thanks for having me, Gopi. I'm doing great. How are you?
I'm good. It's so nice to have you on. I have like this running list of people that, I want to have on, and you've been on the list. I tell you this, truly, you've been on the list for the last couple of years because I've heard you speak with Dr. Ron Mitchell. I got to contribute to a chapter of one of your textbooks. And so when this opportunity came up, it was like, okay, cool. So I'm really excited to have you on as a guest here.
Well, that's very kind of you. I'm excited to be here too. I've heard great things about your show, and I look forward to our conversation.
Awesome. Well, before we get started, can you tell us a little bit about yourself and your practice?
Sure. So my name is Raj. I live in Cleveland, Ohio. I've done a fellowship in rhinology and skull-based surgery. I moved to the Cleveland Clinic back in 2010 to build the skull-based program here, and I'm co-founder of our minimally invasive cranial base and pituitary surgery program here. Much of my practice is skull-based surgery, orbital surgery, and kind of complex rhinology, but I, do a lot of general rhinology as well, septums, polyps, all the usual stuff that goes with rhinology. We, of course, have a residency training program here that I'm involved in, and we also have a fellowship that we started around 2013, I believe, and we're in the match cycle for that. At the clinic, I have a variety of different roles. I have a role in surgical operations. I'm vice chair for enterprise surgical operations. I've been past president of the medical staff and on the board. So I kind of look at healthcare through a bunch of different lenses, depending on the day and depending on what hat I'm wearing as far as work goes.
That's awesome. Well, today we're going to talk about navigation. It's kind of like the backbone, especially some of the advanced sinus and skull-based surgery. Tell me first, when do you use navigation? Is it one of those where when you post a case, it's an automatic thing on your card? Or when you're posting a case, you actually add, okay, this is endoscopic sinus surgery with navigation. Like, when do you use it?
Yeah, that's a good point. Here, because I think the nature of my practice is more complex stuff, I don't have to check a box. They do have it in the room, and the residents know to set it up pretty much with every single case. But kind of as a more broad question, when does one use navigation? I would say it's whenever you're doing something complex enough, different enough, that you want to have a little bit more localization and orientation. That could take a lot of different forms, but usually when we're in the posterior ethmoids or sphenoid, most of us like to have navigation or doing frontal surgery. Certainly in the scenario of tumors, skull-based orbit, when you're going to be up close to some pretty important landmarks like the lamina or skull base, you want to have navigation then as well. But we've done some complex maxillary sinus cases in the setting of trauma or tumors, where even for maxillary sinus surgery, you would want to have navigation. And when you look at some of the position papers or even the Academy's statement on navigation, It's purposely general and vague. And the idea is really when you think it would help you to be more oriented, visualize better, or localize better, you should use it.
Yeah. No, that's a great way to put it, because sometimes, when you might be at a place where maybe the navigation system is maybe dated or it's not always available. And so when you are having to decide, how to post a case, where to post a case, you have to really think, am I going to use navigation? And if most of your practice is complex, or, you're using it routinely, it's going to be automatic. But when it's not as common, sometimes it does have to be something that, okay, I need to think about, and where am I going to do the case? Do you ever find situations where navigation hurts you? Like, is there ever a time?
Yeah, I don't know about hurts you. It can kind of frustrate you and delay you seemingly, right? Because if it's off and you're using it to make a decision, am I in the right spot? Am I past the area that I wanted to be in, and so on? You want your clinical acumen and suspicions to trump anything a machine or a tool is telling you. But sometimes when you're trying to corroborate that, things can grind to a halt for a few minutes until you troubleshoot what the system is telling you versus what maybe you believe to be the truth as far as anatomy and landmarks. So it can certainly be frustrating. And I think that's why relying on some of the newer systems that really do help kind of maintain accuracy and flag to your attention when things are awry can be very helpful.
Yeah. And we're going to get to troubleshooting, because I think that that's something that everybody has had to deal with at some point. But before we get there, so let's say a patient comes to your clinic, let's say it's a new patient, and it's, some sort of sinus pathology. What on your history or physical exam on the image makes you say, okay, we're probably going to need to use navigation, and this is how I'm going to use it? Like, how do you start thinking about it upon evaluation?
Sure. It kind of gets back to that idea of visualization. But as I'm speaking to the patient, from a historical perspective, or even certainly by the time you get to look at their imaging, it has to do with the complexity of the problem, the disease process, and the complexity maybe of the surgery or the approach that you're going to be using. So if the patient tells you, I've had prior sinus surgery before, or I've had radiation before, or trauma, right away before you even look at any imaging, you know that the anatomy is not going to be normal. It's not going to be straightforward. And you might appreciate at one point or another during that surgery, once you get to it, having an extra tool to help you stay oriented. So those are the things that I'm listening for. By the time it gets to the navigation, the imaging, then of course you are looking to see how abnormal the anatomy is, and then how extensive the disease process is as well. Again, we're lucky because in sinus surgery, the more routine sinus surgery, we have fixed bony landmarks. When you're done, the sphenoid face is there, the skull base is there, and the lamina is there. Everything else can kind of come out depending on what the indications are for surgery. So as long as those main boundaries are kind of in mind, that's sort of where we start thinking of how navigation can be helpful. Now, in the setting of tumors, whether that's sinonasal tumors or certainly intracranial tumors, as you know, we use navigation not just for the bony landmarks that I mentioned, but also for the soft tissue that we'll also be manipulating during surgery. So it's not uncommon, and actually in our practice, quite routine to get CT imaging, high resolution, less than 1 millimeter, and also MRI scans with a skull-based protocol to be able to superimpose those images that we'll use together for the approach, the resection, and also sometimes to help with some of our reconstructive options as well.
And are there certain cases where, I guess, in the case of where a patient might have a tumor, but where they, when are you like, okay, let me go ahead and get an MRI because I'm going to need MRI image guidance as well as CT image guidance? I imagine, the skull-based pituitary cases, but if you could expand on that a little bit more.
Yeah, so anytime you're going intracranial or doing any CNS pathology, whether that's pituitary, meningiomas, and so on, as your viewership knows, CT show us bony landmarks and MRI is better for soft tissue. So when we're actually operating on soft tissues, it's helpful. That includes sinonasal tumors as well, because you'll want to be able to know the detailed anatomy of the tumor, not just the bony box, i.e. the sinuses that the tumor is sitting in or that you'll have to traverse to get into the tumor. Other kind of sort of softer calls might be if you're worried about an orbital dehiscence. Sometimes it's easy to plan out the lamina and you can kind of see it as a straight line. Once in a while, you'll notice some gaps in it. Now, if it's next to an aerated sinus, like the ethmoid is aerated, you may be very clear and obvious that there's an dehiscence of that lamina and some orbital contents pooching into the ethmoid. sometimes in the setting of disease, you can't tell that so well between volume averaging of the thin bones already and so on. So that's one indication where I think it's very wise to get an MRI. If you are suspicious that there's been an orbital injury in the past and you have some orbital contents that might be in your field. Of course, CSF leaks with soft tissue in the area of the bony defect, you'll want to get an MRI as well, not just to characterize the extent of meningoencephalocele that might be present, but we also use MRI, as you know, to look for stigmata of IIH, for example. So the disease process also dictates what imaging we get.
Yeah. Talk to me a little bit about how you use navigation in your preoperative planning.
Sure. The preoperative phase, I think the navigation systems can be very helpful in. And for many years, we've kind of looked at the CT scans, whether that's in the operating room or at a different terminal, like on your desktop, for example. You can get software that lets you interrogate the anatomy and really kind of get your bearings on what it is you want to accomplish during surgery. So the preoperative phase kind of has two advantages, I would say. One is for the surgeon themselves to be able to highlight, and there's a building blocks technology with some of the newer systems like the Stryker SYNPOSIS system that actually lets you highlight and physically outline the different cells that you'll be encountering. For example, during frontal sinus surgery, we have anterior and posteriorly stacked cells. You can literally outline them and then actually with a marking pen virtually kind of plot your way up into the frontal sinus. Now, up until many years ago, and really till the advent of this SYNPOSIS system, that's where it was left. Then you would show up the next day or the next week for surgery, and you had to do this mental aerobics in your mind for where those cells actually were. Now, with the augmented reality features of this system, you can actually see a superimposed view of your preoperative planning stages while you're operating on the endoscopic field. That actually is a very revolutionary change because, as I mentioned, we're all used to using navigation, but it's kind of been a point and shoot. Am I in the frontal? Yes or no? Or here's the pathway I'm going to take. Never did we actually reconcile what I wanted to do preoperatively to what I'm actually doing intraoperatively. And that superimposed view lets you kind of follow the breadcrumbs, as it were, like with a heads-up display in our car, to actually getting into the frontal sinus. So that's been a really big leap forward, right? Because you're now actually using the visualization as it was meant to be when you were planning it out. And then the only other point I was going to make is for residents, it's fantastic because even at the terminal, they can make sure they know what the Augmented cell is, what the bulla is, what our plan is, and we can kind of make sure that we stick to plan when we're doing the surgery.
So the mapping and that sort of planning, is that something you have to do in the OR on the system, or is this something that you can do ahead of time in clinic with your patients?
Right. So I wouldn't necessarily do it with my patients, but I may do it with my resident or fellow. And it can be done just before you start the surgery by standing at the terminal, or you can just get the software uploaded to any desktop, and you can actually do your planning a night, a week, or even a month before. And then those plans that you made are saved, uploaded to the system, and reconciled on your screen.
Yeah, no, that's really cool because then you kind of thought about it, you've kind of drawn it out for yourself, you have an idea, and then it's up seeing it again for the first time in the OR. You've seen it again, you have it right there. And then that's the same that gets then uploaded at the time of the case. Those markings are there, that pathway that you've...
Exactly. And you can shut it off if you don't want to see those cells. You can leave the painted line that you can literally follow with a tracked instrument, or you can just rely on the point and shoot technique that we're all used to as well. I think a few other things you can do is you can try to make yourself extra safe if you notice an abnormal landmark, like, in our world, a low-lying anterior ethmoid artery becomes sort of in your field when you're doing an ethmoidectomy. Again, harder to notice sometimes and potentially at risk for injury during significant diseased ethmoiditis. So you could also put an anti-target on there, or if you're trying to get to a certain place like the frontal, you could use that as a target. So this idea of target, anti-target, you could also use the software for that to try to keep yourself kind of extra safe. So we're actually at the stage now where if you have a tracked instrument approaching one of your anti-targets, whether that's a segmented out entire lamina papyracea or skull base, or just that point or two that you put on the anterior ethmoid artery, the system will actually start knocking as you get, closer and closer to it. So there's a lot of active use of this, and there's actually feedback to the surgeon rather than the old passive sort of point and shoot use of navigation. It's kind of come into its own, if you will.
So when it starts, quote, knocking, is it a bell that starts to go off? How does it alert you?
There's various settings. You can kind of customize it. You can even shut it off if you like. But it actually is a knocking sound. I like the knocking sound, like you're knocking at the door of something that you maybe don't want to answer for. So that kind of thing. But there's a lot of customizability to it. But I think the idea now that the system is along for the ride with you and actually giving you active real-time feedback is something new, right? When I was a resident, we didn't have that kind of stuff. It was very passive. Now it's quite active and getting to the level of being actually very smart, like the rest of the technology we use on a day-to-day, everyday basis.
So this technology is very smart. How did you get facile with it? Did you have to do training? How did you get to the point where it wasn't taking an extra hour to map it out? And, you started to just, it was part of your workflow and you knew what settings you liked and how to use what.
Right. I mean, some of it certainly was trial and error, just getting used to what you like. How loud do you want the knock? Do you want it to be a knock, etc.? But it actually is pretty intuitive. And much of the work, like in our real, sort of day-to-day, because it is smart technology, it kind of learns what you like, and it kind of has all these profiles that you can set and save for yourself. So it actually is not much of a barrier to use, and it's actually pretty easy to set up and easy to navigate through.
That's cool. So, okay, let's say, you have the patient, it's the day of surgery, you've gone to holding, you've, already signed, quote, done the consent, signed the patient in, you have your preoperative markings and pathways drawn out. What do you do next? Like in terms of preparation, what's your OR setup like? What do you like having things, ready to go? I think with the Stryker system, you can have some of your tools already navigated and things like that. Tell me what you like to do.
Yeah, sure. So they do have some plug-and-play tools that are automatically kind of pre-calibrated. So the first step after you've prepped and draped the patient is you'll want to register. And you can even register prior to prepping and draping actually with that system and others as well. So once you've registered, remember, that's a very foundational step in your surgery. That's where you're telling the computer through a transformational matrix where the patient's face and anatomy are. So doing that accurately and precisely is super important, right? Because everything else builds off how accurate you are and how accurate the system is, rather. So it's a very easy registration process. The system will actually help you set things up. You have a pop-up to tell you how close the emitter needs to be to optimize your accuracy. Then you'll do your registration. And then once I've prepped and draped the patient, I usually have my kind of go-to instruments that are tracked. One of those is a pre-calibrated plug-and-play probe. They have several. You can also use universal adapters to put it really onto anything you like to track, Gopi. You want to track your microturbidimeter blade, you can track that, your favorite curette, whatever it is that you like. So in my hands, I like a straight probe, a curved probe, straight and curved suctions, and then the shaver blade as well.
In terms of when you do registration, sometimes just trying to get it under, I forget if it's, I always feel like it should be between 1 and 2 millimeters or maybe under 1. But even that little bit of difference is kind of a big deal when we're talking about millimeters. How do you help make sure your accuracy is good? And also so that, what do you do when it's constantly failing, right? Like you've tried to register it like 3 times and you tried it, the resident, the fellow, everybody's trying to do the thing and it's the same. Talk to me about that.
Right. So, the newer systems do help you with that because they make sure that the emitter, for example, a pop-up will come on and it'll help you optimize where all of those pieces need to be so that you have the appropriate field volume for that registration process to take place. The other thing with the Stryker system is it actually will tell you where to go to collect those points so that the system is optimally registered. So you're not just randomly, picking points on the face. It will actually highlight with a display that comes up on the monitor that it wants more points, near the right side of the eye or near the nasal bridge or whatever the case may be. So I think there's a technology lift there that actually has come a long way to make sure that we register accurately, since it is such a foundational principle. I think beyond that, what you want to do to make sure that you trust the accuracy of the system is not rely on any one number. I mean, yes, there's going to be a green, yellow, or red that's going to let you proceed to the navigation phase of your procedure. But as long as you get past that, meaning green light that it'll let you track, then I would tell you to forget what that number actually was, because it's an average. And actually, sometimes those numbers don't even mean millimeters of accuracy, even more complex than it needs to be. I think sometimes, but you'll want to use your clinical judgment. And so, I like to scroll down the nose after I register, look at the sagittal view to see how tight that registration looks to me by my eye. And then once we start, I purposely will put something tracked against a known clinical landmark. So that scenario, we said, well, I'm not sure if the navigation's accurate or not. Well, then try to get some sort of corroboration. Touch the back wall of the maxillary sinus, the front face of spine, the sellar face, for example, during pituitary surgery, where there's a landmark that you know to be what it is, and then you can look at all three orthogonal views to see how accurate the system is before you make any big decisions.
Got it. In terms of, so your landmarks, a lot of them are in the sinus. Do you ever use landmarks like the lateral orbital rim or between the teeth, anything on the surface of the face?
Absolutely, you can. And, with surface registration, which is what many of the systems now use, you can pick those point landmarks, usually the lateral orbital rim, the nasion, columella, things like that. But, sometimes all of us have had this experience where on the surface it looks pretty good. But then you go,
put it in,
right, you go 10
off.
centimeters deep and it's not so good. So a few things you can do is make sure you register more laterally and posteriorly on the face. I mean, these are some of the things that we really are trying to work through, because where you're registering is kind of not where you're operating, right? You're operating much deeper than that. And you want to make sure that the fidelity of that registration is still holding up as you get deeper and deeper into the head.
Yeah. Tell me a little bit, you'd mentioned you like the straight and curved suctions navigated as well as your pointers, straight and curved pointers. I know some of the systems you can put the tracker on, as you had mentioned, the microdebrider or other instruments. Do that routinely? How does it help you? When do you use tracked instruments? Is it just for teaching purposes?
Yeah, it's not just for teaching purposes, but that is certainly an example or sort of a user case for it. I think the main reason to use it is to make you more efficient, more effective, safer as a surgeon. So I think that just depends on what people like to track, right? Some people like to track curettes, and that's the beauty of these systems that offer this type of customizability. You can, like you said, track whatever you like. Those happen to be my favorites only because sometimes to find your way into the sphenoid, a probe is helpful. Otherwise, I like the suction because you're so often clearing your field. So this is a practical matter. That's where I tend to lean to. In fact, we could use the microdebrider as an example of how the education piece might be of importance from a navigation standpoint. The one way that navigation can help us when we're training fellows and residents is it's kind of sometimes the final arbitrator, right? So if I say that's the anterior ethmoid artery and they say, well, I think it's over here, then the jury's out, we bring in the navigation, and lo and behold, the staff is right. So that's one way to reinforce that as an arbitrator of what the anatomy truly is, as long as it's accurate. And the second way that I think it helps me as an educator is, unlike many other surgeries, I would say, that otolaryngologists or anyone else does, there's only ever one surgeon at a time in a very real way. So if a resident is operating with a powered instrument like a shaver, for example, imagine, Gopi, by the time I say, no, not there, here, it's kind of too late, right? And so by having the tip of that shaver blade accurately displayed on the monitor, it lets me relax a little bit, knowing where that tip of the instrument is in a field of blood, in a field of a lot of polyps and things like that. So those are the two examples I would cite as how it really has made us better educators as well.
Tell me, do you feel like the navigation systems have made a difference in operative time or cost with certain cases, or?
Yeah, I mean, it's a good question because we're always, especially in this climate, right, always trying to justify the capital and then ongoing disposable expense related to navigation or really any technology we use in the OR. And I would tell you, it's hard, right? It's a hard study to do because of the many variables that come into play. Appreciating that there is an upfront capital cost and then ongoing disposals, I think it's still very worth it. As you know, there is a billing code, a CPT code, that you can use for extradural navigation, 61782, and then 61781 is the intradural navigation. So you do get some reimbursement for using the navigation. The idea is it should kind of offset some of the costs over time that you're using. Different studies have looked at this exact idea of does it make us safer? Does it make us faster? And so on. And it's kind of hard. I think it's kind of like that parachute study. Now it's in everyone's OR. We use it routinely. So it's hard to pause and, randomize people to using navigation and without, when the major complication rate for sinus surgery is so low to begin with. So I think if you ask 100 people using it, I think they would say, yes, it makes me a more confident surgeon because I'm continuously corroborating what I think, where I am and what I'm doing. So it makes us more efficient. I think it makes us more effective. And I do think it makes us safer as well.
Yeah, I usually feel safer. And honestly, like when I talk to families, all my patients are pediatric. And when I'm talking to families about sinus surgery and you're explaining what you're doing through the nose, when I can at least say, listen, it's a camera, but I also can calibrate my instruments to the CAT scan. And, because, you go through the risks of sinus surgery. Yeah, they're thankfully not high. That being said, it's nice to say that I have calibrated instruments and a CAT scan that I'm using at the time of surgery, like real time. And so I think that it's helpful, and I do feel safer when I do have my navigation ready to go.
I totally agree. And it's interesting you mentioned the patient dynamic, because I do mention it to patients as well. When I tell them to get the CT scan specifically to the protocol that I want, I mention, this may be a pain to come back to the main campus or to go wherever in our enterprise to get it. But the reason I'm doing it is because then we can upload it in the OR, and like the GPS on your car, Mrs. Jones, it can help me stay safe, stay in the lane I want to stay in. Because GPS, if you think about it, or navigation, is literally commonplace now, right? It's on every one of our phones, all of our cars. And in fact, you might argue it's to the nth degree in our everyday world, yet we're still kind of walking to it in the operating room, I think.
Well, it sounds like with these new systems with the safety augmentation, you got a little, a vibrator or knock or whatever, a light that flashes if I'm switching lanes or, getting off track. So getting too close to important structures that I don't want to get close to as well.
Absolutely. And I think that idea of using some of the technologies that do come from, the same idea of our navigation in our phones or our cars, like using augmented reality or virtual reality, which is part of some of these systems, is just one more element of that, of staying oriented and knowing where you are. So I think being able to use that, and I do make the point that you want to make sure that you're using all of your visualization tools together in an ecosystem to make you as safe and effective as you can be. And I think navigation has really come a long way, I think, in that regard. For many, many years, it's been kind of a stagnant field. But now as we introduce some of these new AI-like technologies, I think it is taking things to the next level. It's active. It warns you. It tells you when your registration may be off a little bit so that you should check and corroborate with landmarks. And especially when we use this target, anti-target software as well, I think it just is kind of changing the game.
Yeah. So do you use any navigation for in-office sinus work in your practice?
Yeah, we are just doing more and more in-office surgery. As you know, all of us are kind of dabbling in it. And especially if you can get the same goals met rather than being in the high-price environment of an operating room, it makes a lot of sense from every dimension. The insurance companies, the surgeon has an easier time scheduling it. And of course, it's the best for the patient because you don't have to worry about the risk of general anesthesia or really the inconvenience of having to go to the operating room. So I think, this idea of wanting to know where you are and being accurate makes sense whether you're in the OR, in an ASC, or in the clinic. And you would think that maybe in the clinic setting, there may even be an argument to be made that you want to be more, localized because the patient's awake. They could move. They could, only tolerate so much, so to speak. So you want to be efficient in getting in, accomplishing the goals, and coming out. So I think, I think the same rationale should hold true regardless of where you're doing the surgery. You need to know where you are, know where your landmarks are, and know where your, quote, no-fly zones are. And that should hold true in the clinic environment as well.
And you also have some of the same navigated instruments as well with some of the if you need a microdebrider, potentially, depending on, what your plans are as well.
Exactly. Yeah. So whether you're doing a balloon procedure, you're usually doing more minimally invasive things in the clinic because it's an awake patient, but exactly from the balloons to your other instruments, including curettes and microdebrieders, you can track them all the same way. And I think that's a nice way to get facile with using the systems as well. Do some of it using a patient that's under general anesthesia, then you get facile with it, and then you almost crave it when you're in the clinic as well, so that you can do the same, at least, level of surgery, if you will, from a completeness standpoint, even though the patient may be awake.
That's a good point. Tell me about, what are you looking for in a system? I mean, there's so many different systems out there. And I'm not saying, Raj, tell us, what you think is the best system, but really sort of what are the qualities that you look for navigation, I guess. And then, sometimes you'll find yourself, most of us will enter a group, a practice, a hospital setting where there's already a navigation system there. If you've been there long enough, at some point, you're going to hit a crossroads where you either have to upgrade the system or change systems. Maybe that's the better question. How do you know when to upgrade or change, and what is important to have in a good navigation system?
Right. So, each of these systems may have a little bit of a different half-life, and the companies will tell you after a certain point, they're no longer supporting it for X, Y, or Z reason. So that would be a hard stop where you'll want to have control and support for things, like next generation instruments or whatever the case may be. But, other than those hard stops, the system stops working, or it's, you don't have the parts and the pieces that you need to make it work effectively. I think there's a couple of different things that you would look for, and even agnostic to company. I think everyone from a user standpoint would agree things like ease of use, accuracy and precision, customization, and then a few other things. Like I even might mention the wow factor. So first, from an ease of use, you want the registration and setup to be easy. You want to be able to switch fluidly from using one instrument to the other, and you want to make sure, of course, it's accurate and precise. Again, I like the newer systems that have pop-ups to say, yes, the emitter is too close or too far, you need to move it this way. And even if there's a degradation in accuracy, as annoying as it is sometimes to have that screen flash where it says, the accuracy is different now, it's nice and it makes you feel like you have kind of a co-pilot in that computer that's in the navigation system. The third thing I mentioned was customizability or customization. I think that has to do with this idea of tracking whatever it is that Dr. Shah likes to track or Dr. Sindwani likes to track. And these universal adapters really go a long way to making whatever you want to customize kind of your own thing. So if you don't like the straight pointer, great. There's a malleable pointer. There's a curve suction, etc. And then I think even just being able to personalize under profiles your screen setup. Do you want a larger coronal view or a larger endoscopic view? You can even use a lot of these on just one monitor now because the fidelity of the monitors and the whole visualization system, again, getting back to that idea of ecosystem, which I like to look for because I want all these key pieces of technology to play well together during my surgery, might be another thing. Now, I did mention the wow factor and kind of how forward-facing is the technology I'm deciding to go with, or maybe even the company that I'm deciding to go with. And that's just because there's a lot going on in the navigation space, right? I mean, even though I'm saying it's a tool, it still is a very expensive tool that you're going to be using for a while, and there's going to be iterations on it. So I wanted to make sure something has software upgrades available, has, kind of the next best thing just around the corner, or at least the company's looking for that next best thing. And you could even say that they're a good partner and are engaged in trying to help your residency, your courses, your, patients in the broader sense do well.
Yeah, no, those are all great points. Have you ever been, in terms of navigation, I think of FESS, I think of neurosurgery, I think of ENT. In your hospital, are you guys all using the same navigation, or do you find that, some services like this system and other services like that, how do you sort of think about that? And especially because you were the chief of surgical operations, so I'm sure those things may have come up, whether it was for this or other instruments and technology.
Yeah, no, I mean, all those, let's call them practical considerations are very real, right? Because these are, at the end of the day, expensive purchases. And so the more service lines or more specialties you can get to use any one piece of equipment, the better is going to be your argument for purchasing that piece of equipment. It's a little bit harder in ASCs because you have a smaller number of surgeons potentially operating there. You might have 3 or 4 ENTs and 2 or 3 orthos and so on. We're kind of lucky here at the Cleveland Clinic. We have so many otolaryngologists alone. I mean, we have now coming up on 5 rhinologists. So we have our own systems, plural, and we've actually been able to play with multiple different vendors as well in that regard, which lets us compare and contrast, getting to our prior discussion. But it's true, if you have a group that's going to be using them in a shared manner, you want to make sure that those systems do offer spine software, neuro software, and so on. It's interesting that you mentioned that. Currently, there's a lot of overlap between neuro and ENT, right, in rhinology specifically, because of our skull-based procedures. So when we're doing a case in my neurosurgeon's room, we happen to have several systems, as I mentioned. We may use a different system, and in the ENT room might be a second system. And I think from a training standpoint, that's actually kind of a fun environment to be in, because in a very real way, you get to see pain points over here and solutions over here and vice versa, because there may not be any one perfect system for all things considered.
How does that go, though, with your OR staff? So now I want to kind of talk about, troubleshooting, familiarity with systems, whether from the staff standpoint as well as the surgeon standpoint. I mean, you may not always be operating at the same hospital or surgery center, so that you may not always be using the same system, or you may be taking call and something needs to go in on call, and this hospital has a completely different system than what you're used to. Tell me a little bit about troubleshooting and systems that have helped kind of with some of those problems.
Yeah, no, and it's a really good point. And of all the things I mentioned for what you might consider, ease of use, which is what you're getting to now, might trump a lot of different things. And, I would admit my lens is through an academician. So I've got a fellow, a senior resident, a junior resident, and 3 other people deep that are going to troubleshoot before I feel that friction, right? So I'm very sensitive to the insular environment that I live and play in, so to speak. But if I was on call, like you're saying, and you're going to a community hospital and there isn't that type of support, and obviously from a company standpoint, I'm sure they would love to have a rep at every one of your cases, but that's going to be hard to assure. I think ease of use would absolutely trump some of these other considerations, because it does have to be plug and play, easy to set up, easy to troubleshoot, not just for you, the surgeon, because now you're scrubbed, but also for your entire team. And I think, the companies that we partner with really go out of their way, I think, to make sure that the scans are easily downloaded to the system, that it's 1 or 2 buttons to get the thing fired up, that it keeps Dr. Shah's, profile for how she likes things set up saved, so they don't have to kind of reinvent the wheel. And they spend a lot of time in servicing for our scrub techs and our nurses, as well as, in my world, for our trainees and the surgeon. So I think getting familiarity is the point. In the normal course of use is super, super important for those late nights, for those unexpectedly complex or twists and turns we all experience in our cases to go well. I think once you're in that scenario, though, things that can introduce errors or inaccuracies that you want to be on the lookout for, one, outside of just the software, the registration paradigms that vary system to system, would be things like movement of the patient tracker that's placed on the forehead, movement of the patient's head that might be turned out of the volume box, for example, bent instruments. We talked a lot about universal adapters, so those could slip if they're not on tight enough. And again, often it's the scrub tech that's kind of tightening them down. So these are all things that you should be on the lookout for. And again, the way you confirm that there may be an issue is checking against or corroborating with intranasal, ideally, clinical landmarks. So once that happens, again, with the Stryker system, it's going to prompt you saying, well, the accuracy may be off. And it's actually a hard stop that you have to click past when it senses the system that something may be awry for you to corroborate or then re-register. So that at that point, you're going to just try to decide what it is you want to do. You've got a couple of options once you've checked those intranasal landmarks. If they're not accurate, you can say, oh, well, I'm not using this. I'm going to keep going because you're almost done or you're confident with your landmarks. Option 2 could be to re-register. You'll look to the system to tell you that, and you'll get a sense of whether the registration or the patient's tracker slip, for example, you'll want to re-register. And if you think it's an instrument issue, like you notice that universal adapter has shifted, you want to recalibrate. So registration is the patient's head and that interplay. The calibration is the actual instrument that you're using itself. And then I think those are the main things that you would want to look for. I think the key is just when your, spider sense starts tingling like things aren't right, then I think it is worth pausing and deciding on which of those few things is going to be your next course of action.
Yeah. Have you ever had to call your rep, on the weekend or in the evening because everything you've done isn't working and we haven't started the case, the patient's been on the table for about 30, 45 minutes because, or I don't know what your threshold is with time, but like yours, and it's a FESS in the setting of a large subparietal abscess. So it's super swollen and there's concern about vision, so time is of the essence.
Yeah, and you want to have that nav in those settings. You want to have that extra buffer of safety and confidence as we've been discussing. So yeah, you're pointing to the fact that you do want support in these cases. So You don't want to partner with a company that just drops the nav off and says bye-bye and they're on to their next site or their next sale. You do need to partner with the local reps who should be available, amenable to helping you out. And, it's interesting you mentioned that, because I'm just, thinking back years ago, I remember that happening not super infrequently, but more recently, I think with the newer systems and so on, I would say I think that happens a lot less, where you actually have to pause, break scrub, or have someone FaceTiming, right? And saying, I don't know why. It's the worst. You're stressed. There's a patient asleep. And you're just there, it's coming at you from all dimensions. So I have been there, I have done that, and I've hated it as much as you. So I think making sure you're partnering with the right folks in this regard is going to be super important.
Well, the other thing is, I feel like, the training for the staff is something that has to happen like every 6 months and then eventually once a year, because there's so much staff turnover too. And so, you might have that person that knows your system and, or the 3 people that really know it, but, maybe they're all gone after 2 or 3 years, and it's like starting from zero again. And then nobody wants to scrub that case because, it's a new system. And so you're right, having a partnership and a good relationship with your rep, the company, I think is vital. And you want them to want to come to your hospital. You want that, that the nurse, the OR charge, whoever the tech can get a hold of the rep as well. It's not just that you're the middle person, like that communication, those lines are already open. And the other thing I find helpful is literally like a step-by-step of what to do, from plug in, navigating system, turn on power. I want everything like that. Dumb it down so that when I go, I'm just like, okay. And so it's not, so even taking the time to kind of make little instruction things on every single system, I found was helpful for us.
Yeah, no, that's really good advice. And I agree, because of, the current state of affairs in our healthcare industry, there is a lot of turnover or off-service personnel who just kind of pop in for a case here and there. And there's always that on-call example that you cited where it's not going to be an otolaryngology nurse that's going to scrub with you. So those things do get people nervous, and I think it's the best laid plan sometimes, right? So I think the stronger the team is that you can surround yourself with, the better your outcomes are going to be in every regard.
So Raj, any final pearls or thoughts on navigation?
Yeah, I guess parting thoughts would be, navigation is at the end of the day just a tool. It's a cool tool. It's amazing. It's empowering, all the things that we've highlighted today in our discussion. But it is still just a tool. It doesn't make a poor surgeon a great surgeon, and you want to know that it has limitations, and ultimately you're the one responsible for the outcomes that you get. This can just kind of enhance and help you along the way. So I think that deserves being mentioned. And I guess the second thing to end on a positive note, I would say is, I really feel like we're at an inflection point for the world of navigation, or this space. As I said, for literally 2 decades, it's been a kind of a stagnant area with not a lot of innovation. And again, if we contrast it with the way we use navigation in our everyday lives, clearly there's so much potential here with the application of AR, VR, and all those things that now we're starting to really see come to fruition. And it's been really exciting to see what some of the opportunities are here for expanding the boundaries of skull-based orbital and rhinologic surgeries, and also what we can accomplish together for our patients.
That's awesome. Well, thank you so much. I really appreciate your time. I learned a ton. If any of our listeners want to reach out to you, if they have any questions, are you on any social media?
Yeah, I can forward you all those links in my email, and I'd love to hear from some of your listeners.
Awesome. Well, thank you again, and I think it's a wrap. Thank you so much.
Thanks, Gopi.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BacktableENT on Instagram, LinkedIn, or Twitter. Backtable ENT is hosted by Gopi Shah
and Ashley Agan.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles,
Nick Shellcross,
Josh Spencer.
Design and digital marketing led by Brian Schmitz, with support from
Taylor Spurgeon Hess,
Social media and PR by Chi Ding.
Administrative support provided by Jamila Kennebrew.
Thanks again for listening, and see you next week.